Hello, everyone. Thank you for joining us today. We're going to go ahead and get started. It's noon. I am Jody West, but I am changing my name to Strother. So just so you know, if you see that name, that's still me. This is our second session of the third series of the PPCL Perinatal Mental Health Tele-Echo. I'm the coordinator of the ECHO, and I wanted to just go over a few housekeeping items before we get started. It would be lovely if you could turn on your cameras if you're in the position to do that. But this is our agenda, and we're going to stick to it as closely as possible. We'll do a brief introductions with our facilitator, Dr. Juliana Finelli, and then Dr. Bruno is going to present our didactic presentation. And then we will shift to a case presentation by Margaret Smith, and we'll have time for clarifying questions, recommendations, and then we'll wrap up. So at the end of the session, everyone will get copies of the slides as well as the recommendations that go to the case presenter, just in case that could come in handy for you. So what I'm going to do now is just hand it over to Dr. Finelli for introductions. But before I do that, I'll go ahead and just introduce myself again. Not only am I the coordinator for the ECHO, I'm also the program manager for PPCL. So the provider-to-provider consultation line provides consultation to providers like yourselves around any topic that's mental health focused for both pediatric patients, which is 0 to 21, as well as perinatal patients, which is pregnant and 1 year postpartum. In addition to those consultations where you can call us to ask specific questions about the care that you may be providing, seeking referrals and resources in your community for your patient or client, we also have this training arm that includes the Tele-Echo series. So if you're unfamiliar with PPCL or the different services, if maybe you only attend trainings, but you haven't given us a call for consultation, you can look at our our website for more information. You can scan that QR code. But I just wanted to make sure that everyone understood the whole breadth of services that PPCL does provide. So I'm going to go ahead and hand it over to Dr. Finelli to introduce the rest of the hub team.
Thanks, Jody. Hi, everyone. Thanks so much for joining. I'll quickly introduce myself, Juliana Finelli. I am a psychiatrist at Tulane. My clinical focus is infant and early childhood psychiatry and perinatal psychiatry, and I serve as the facilitator for these sessions and also a perinatal psychiatry expert. So I'm going to pass it over to Katie Hebert.
Hey, everyone. I'm Katie Hebert. I am a licensed clinical social worker, as well as my focus being perinatal. And I am in private practice at Bloom Mental Wellness in Lafayette.
Thanks, Katie. I'll pass it over to Dr. Zena.
I think she's going to be late.
Oh, I'm sorry.
Oh, I'm here. I made
Okay.
it.
I just saw her.
I'm Paula Zena. I am a clinical psychologist and also bring up a pediatric nursing perspective. I have expertise in infant and early childhood mental health. I'm a professor in the Department of Psychiatry at Tulane.
Thanks, Dr. Zena. And Elena Raguette.
Hi, everybody. My name's Lena Raguette. I'm one of the mental health consultants for PPCL and also helping out today as kind of IT backup. So good to see everyone. Nice to see all those familiar faces.
I think since we already kind of discussed the PPCL program, I'll turn it over. We're very lucky today to have Dr. Bruno, who is the expert, and she's going to be presenting. So I'll turn it over to you, Dr. Bruno.
Okay. Can I just jump in or do I have to introduce myself? I'm ready to go. Okay.
Go for it.
Psychiatry, child trained, winding down after 30 years. But let's jump in. Today, we're going to talk about a potentially devastating health condition. It's a health condition which negatively impacts pregnant people, both physically and mentally, and it has links to poor outcomes. Next slide, please. We're going to start with the definition. You know, in psychiatry, we're used to symptoms and illnesses being defined in a spectrum, and I think hyperemesis gravidarum, which is the illness we're going to be talking about, also is within a spectrum. Most of us know that it's fairly normalized that in the first trimester, women have nausea and vomiting of pregnancy. In fact, up to 70% of pregnancies have those symptoms, and up to 30% of those women are prescribed anti-nausea or anti-vomiting medicines called antiemetics. You may know names like Zofran, diclofenac, Spongesta, Unisom, vitamin B6. But hyperemesis gravidarum is a more severe form of nausea and vomiting in pregnancy, and it is relentless and potentially devastating to one who suffers. Um, the the criteria that have been put out involves more than 5% of pre-pregnancy weight being lost, but we can't really stick to that, because if we stick to that, it may lead to OBGYNs really minimizing the severity. So we don't get hung up on the weight specifically. It typically begins at 4 to 6 weeks gestation. And for some, those who are the lucky ones, it turns off at 14 to 16 weeks, but others, it persists through pregnancy. It happens in anywhere from 0.3 to 11% of pregnancies, and it's a leading cause of early hospitalization. As we'll talk about, it's commonly associated with thoughts of pregnancy termination and even suicidal ideation. Next slide, please. So what we know is, I would say this is an ominous slide. It's long been associated, hyperemesis gravidarum, with peripartum medical conditions, which are on the left, but also peripartum, postpartum psychiatric illness, and even extending to negative outcomes for the infant and for the dyad, and even for the developing child. And so this is just a snapshot to let us know the far-reaching consequences that can happen as a result of hyperemesis gravidarum. But in the next slide, please, I'd like to break it down into some of the areas that are most relevant in considering the importance of mental health. So with this condition, women elect for therapeutic terminations up to 6% of the time. It can cause death. That's how severe the symptoms the medical consequences can be. There are many medical consequences listed here. Upwards of 30% have suicidal ideation, 18% have post-traumatic stress disorder and acute stress disorder while having the illness. About 2.5 or more times likely to be diagnosed with postpartum depression, but there's a lot going on before the postpartum that it's important for us to attend to. And there are other consequences, including 37 to 50% decide never to get pregnant again. Next slide, please. So there's this great study, and I forgot to include the references, so I'm going to send them to y'all. But it was a study that looked at, it was a retrospective cohort study with a control group. And it looked at electronic medical records from 2010 to 2025. So it's a new study, compared women with hyperemesis gravidarum to a control group across 135 different healthcare providers, and mostly high income to middle income countries. But what this study found is there was over 50% increase in 13 neuropsychiatric conditions. And in the study, they looked at 24 neuropsychiatric and mental health related outcomes reported within a year of diagnosis. So this is looking at women way after the fact. And they had a number of psychiatric illnesses. Wernicke's encephalopathy is one that's worth mentioning, because this is where the overlap becomes very confusing and sort of the chicken or the egg question. When one has a thiamine, vitamin B deficiency, it can lead to a condition that leads to confusion, difficulty walking. It's called ataxia, ophthalmoplegia, eye movement problems, and can overlap into causing something called Korsakoff psychosis. So women experience this with hyperemesis gravidarum. And the problem with that, as we'll talk about, is then it becomes lumped in a silo of psychiatric, and then at the expense of not dealing with the medical conditions as well as we should. Other conditions in this study that were known to arise associated with hyperemesis gravidarum were psychotic conditions, affective psychosis, postpartum psychosis, PTSD, OCD, phobic anxiety disorders, adjustment disorders, eating disorders, kind of you name it. Next slide, please. And these are pretty daunting offspring morbidity. And it's interesting that we don't talk about this enough, right? So 2.8-fold increase in preterm birth, low birth weight, small for gestational age, NICU admissions, neural tube defects, increased childhood cancer, cardiovascular comorbidity down the road, and increase in behavioral and neuropsychiatric conditions in children. Next slide, please. So what's been problematic with this illness is that until recently, and still some, it's been fraught with misconceptions as to its cause. And this has slowed the progression in research and treatments and led to women being dismissed or their symptoms being minimized. Especially like if they don't meet criteria, like they haven't lost 5% of their pre-pregnancy weight and that sort of thing. And so, as I said, that has led often to not tending as well to the medical piece. And so for a long time, and even up until recently, I mean, we've just had a surge recently of the research direction we need for hyperemesis gravidarum, but it was called a conversion disorder and a psychosomatic illness. Believe it or not. And so remember, it was thought to be all in her head, or in medical settings, when it's psychosomatic or conversion, it's often thought that she's, deliberately feigning the illness. And we've certainly seen that in hospital settings. But the great news is now we have evidence, strong evidence, that the cause of hyperemesis gravidarum is associated with a hormone, GDF15, which is made in the placenta. And it's a hormone that women can be sensitive to. We know it's why women have morning sickness, but there is a subset of women genetically who have a strong sensitivity to this hormone. So go to the next slide, please. So this quote from Dr. Fazo and of the Her Foundation: knowing that hyperemesis gravidarum is caused by our gene changes everything. No longer are patients blamed for their suffering. Now we can focus our attention on priorities, such as how we can influence the expression of these genes, test prior to pregnancy to know who will develop it, and determine which medications are most likely to help. And this is what's important, even as a mental health provider. So hyperemesis gravidarum in the genetics, in terms of the sensitivity to GDF15, is heritable. So in your history now, after this talk, you will not only ask a psychiatric family history, you're going to ask if there's a history of hyperemesis gravidarum. They're not going to ever have heard that term probably, but of nausea and vomiting that's so severe that it interfered with the health and wellness or led to hospitalization of grandmother, because that's going to give us a hint about how we're going to have all hands on deck for both support and self-advocacy for this patient if she develops it or is likely to develop it. Some of the promising, I'm not sure if I need to go to the next slide, but go ahead to the next slide in that. Yeah, some before we get to this slide, some of the promising research, now that we know it's the hormonally influenced, is that we even know that metformin may help desensitize a woman's sensitivity to the hormone, so there are lots of things going on in research. I'm going to take a little bit of a detour, because any of you who know me, I feel really strongly that we need to treat pregnant women holistically, even in mental health. And even if we're not a mental health a medical provider, we have to help point women in the direction. And nutritional depletion is something that we need to talk about. The second bullet point, I think, is interesting. Understanding the root causes of perinatal depression, including the role of nutrition, may encourage a shift from treatment to prevention and targeting some root causes, and might simultaneously alleviate other adverse health outcomes. So this is really for the general population. And then when you add the depletion that we know happens in Hyperemesis gravidarum, it makes it even more important. So next slide, please. So one of the things you can talk to your clients and patients about in mental health, pregnancy has more nutritional demands, as we see in the bold. First trimester increased by at least 85%. 85 calories. Second trimester by over almost 300 and 500. And then what's not on this slide is then you add breastfeeding to that, and women need 300 to 500 more calories per day just to meet basal demands. If there's hyperemesis gravidarum and she's behind the curve in weight and nutrition, she probably needs a whole lot more than that. But we don't really ever talk about or encourage that in ways that we should. In fact, I'm concerned that the OBGYN focus more on obesity and the problems there, as well as the flip side, everybody's doing GLP-1s, postpartum moms that are going to jump on a GLP-1 in order to lose their baby weight. If this comes on the heels of a hyperemesis gravidarum, it's just a scenario for poor outcomes, not only in physical, but also mental health for us. And these are things we need to be asking about because it's happening. And we need to say, are you considering this? What's going on with how you're feeling about weight and nutrition and those sorts of things. Go ahead, next slide. I thought this was an interesting French study recently where they compared what they called a healthy dietary pattern in France to the Western diet. And the Western diet is categorized by ultra-processed foods and a lot of red meat. And I think, and the lower education levels, as well as what we saw earlier with some with lower socioeconomic status, that we have to pay attention to asking people kind of what they're eating to help them have a more holistic nutrition to help protect them from perinatal mood and anxiety disorders with or without hyperemesis gravidarum. I'm throwing those little sides in, but next slide, please. So, when we talk about what can we do as mental health professionals regarding hyperemesis gravidarum, these are the recommended prevention and early intervention strategies. Protective factors for termination of pregnancy and suicidal ideation include holistic support from family, friends, and healthcare providers. It's all about education, 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 and support and validation. And so from this time forward, I'm going to mention the HER Foundation, capital HER. It's on this slide that has all of the information you need to supplement this presentation to understand what you're going to help her advocate for and understand about her physical and mental health and what direction she should be going in if she has this condition. Optimal care should incorporate timely access to pharmacotherapy, assessment of mental health, and consideration of referral to a specialist. Services and care being delivered in a compassionate manner, not being dismissed, as is often the case. Hydration and nutritional support. I often in my presentations mention iron, DHA, and vitamin D3, and I want to mention a couple of things about that. This recent study that I'd like to, and I'll put it on the reference slide when I send it. Among postpartum depression mothers, 43% had low ferritin levels, which is a measure of iron stores. So sometimes iron and something called TIBC are measured, but not the stores themselves. And iron deficiency, as it relates to postpartum depression and perinatal depression, can occur without iron deficiency anemia. It can occur with only low iron stores. So we must be paying attention to this and helping women advocate to get their ferritin measured. And if you have hyperemesis gravidarum and you can't keep anything down for months, that's when you're advocating for iron infusions, as well as infusions not only of hydration, but infusions that involve something called a vitamin bag and thiamine to avoid things like that Wernicke's encephalopathy. So iron is really, really important. And in that study, where among postpartum depression mothers, 43% had low ferritin, that was compared to 15% in controls. So it was cases versus controlled. So it's interesting. When we talk about DHA, the data is mixed as to whether intervening with DHA would help stave off things like postpartum depression or perinatal mood and anxiety disorders. However, polyunsaturated fats, PUFAs we call them, are essential fatty acids that the body can't make. We have to take them in nutritionally. And both DHA and EPA, the omega-3 fatty acids, are crucial to brain development. In the third trimester, baby takes most of it for the baby's brain, mother left with nothing. You add nutritional depletion for hyperemesis gravidarum to that scenario in third trimester, you're setting a mom up for really deficient or impaired brain function. So I say adding a DHA supplement with a vitamin D. Vitamin D has some interesting data too, and we don't often, OBGYNs don't often measure it. It's associated with gestational diabetes, preeclampsia and hypertension in the mother, and associated with low birth weight in the baby. So I think with hyperemesis gravidarum and general in pregnancy, we need to be looking at supplementing with iron, DHA, and vitamin D whenever we can. If she can't keep things down because of hyperemesis gravidarum, you're encouraging her to sit by the window or sit outside. First morning sunlight, lots of it for vitamin D, or even invest in a light box if she's depressed. Next slide, please. What do? In mental health, we screen not just for whether she's having nausea and vomiting of pregnancy and the severity. We screen for her family history in that regard. We screen for nutrition. And we look at the whole picture. In medical medicine, OBGYN, pediatrics, we screen for mental health. We acknowledge, we support, we turn her on to the Her Foundation website, and we facilitate self-advocacy. Next slide, please. And we do that because 41% of women taking prescribed medications for hyperemesis gravidarum had to ask for them because it was said, you're going to be okay. This is normal. This is part of pregnancy. And the severity was not acknowledged. And extremely poor or poor experiences were described in 40% and 30% in primary and secondary care, respectively. So we have to empower for self-advocacy. Next slide, please. This is from the Her Foundation website, and its treatment strategies help her. Hydration, electrolyte, nutritional. The important thing here, electrolyte and nutritional deficits should be corrected regularly. What often happens when it is acknowledged, it's a one-shot deal. They might get an infusion, they might be hospitalized, but then outpatient, nothing is continued. And in these patients who have prolonged symptoms, up to 16 weeks or longer, they should be scheduled for regular infusions, up to 3 iron infusions, and we want to help them advocate for getting it throughout. It's not a one-shot done deal, because even in the study with neuropsychiatric conditions, up to 1 year, there were problems reported related to both physical and mental health. The other thing is it's really complicated, the hierarchy of where you start with medicine to treat the hyperemesis, but you escalate dose and change frequently, and you change the route frequently. Once the woman is better, you always treat up to 3 weeks past the time she's better for the hyperemesis. Now, next slide, please, and I'll qualify that in terms of mental health. So there are psychiatric medicines that are frequently used in intractable hyperemesis gravidarum. Remeron or mirtazapine, because it comes in an oral disintegrating, it's anti-nausea, anti-vomiting, and it overcomes the food aversion that comes with frequent vomiting, can turn it around sometimes in 72 hours. Thorazine is chlorpromazine, olanzapine, and gabapentin. I'm going to suggest that in the population that also have comorbidities, mood and anxiety disorders, and hyperemesis gravidarum, that you know and understand that these medicines can be used with SSRIs as well. So say she's already on Zoloft for a pre-pregnancy mood and anxiety disorder, and she has hyperemesis. You can add the mirtazapine at bedtime in the evening, and then you can continue the mirtazapine until she's well, then wean off 3 weeks after she's well, and you wean slowly. You always wean slowly psychiatric medicines. And olanzapine, it's also been noted that women who have bipolar disorder and hyperemesis gravidarum, you're not going to want to use mirtazapine because it's an antidepressant, which could cause mood swings. Olanzapine might, or that's Zyprexa. The benefit of Zyprexa in hyperemesis gravidarum, similar to mirtazapine, is that it comes in a dissolvable, so you don't have to swallow it, risk vomiting it and not getting it absorbed. It also comes in an intramuscular injection, which can be given in hospital settings for hyperemesis gravidarum. And again, all of this information is on the HER site, and very much detail with references as well. So I'll stop there, and because I think we're at the 20-minute mark, and see, oh, I didn't mention the psychosocial hyperemesis gravidarum leads to isolation, loss of rule, inability to care for self and family. Again, all hands have to be on deck in involving family and support systems too. See if anybody has any questions.
Thank you, Dr. Bruno, so much. I think maybe we can just like a minute for questions, and then maybe before we get to the case. Anyone want to come off mute?